Go na. Good morning, ladies and gentlemen. It is with great honor and enthusiasm that we welcome you all to day 2 of the 12th International Neonatology Conference happening here at Grand Hyatt Hotel, Abu Dhabi, UAE. My name is Lalaine Delumen, and I'll be your host for today. We all know that the area of neonatology is continually changing, fueled by cutting-edge research and technologies aimed at improving the treatment and outcomes of our most vulnerable patients, the newborns. We are confident that your continued involvement in the conference will be joyful and fulfilling, providing you with useful insights, inspiration, and connections to help you flourish in your practice and research. The conference is accredited by the European Accreditation Council for Continuing Medical Education for 14 European CME credits. We are grateful to all of our sponsors and international hospitals and institutions for their great support and important contribution to the conference. Special thanks to the following: our gold sponsors, Children's Hospital of Philadelphia, USA, Children's National USA, our silver sponsor, KC, our bronze sponsors, AstraZeneca, Wyeth Nutrition, and Nestle Nutrition. Our exhibitors, Hessa Medical Equipment Co. LLC, Gulf Drug, Eon Diagnomics Genome Center, MedPro, Vigan, Al Jawahir Medical Supplies LLC, DuFarm, and Neotech. And now, to officially open day 2 of the event, allow me to introduce our distinguished chairpersons of the conference. Please welcome on stage Dr. Junaid Khan and Dr. Ayman Ramani.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everybody. I would like to welcome the delegates who join us today for our first day, and welcome back the delegates who were with us yesterday. We had a really exciting day yesterday and the day before, and the feedback that we got from everybody is really encouraging. But we'll continue to seek your feedback about the sessions. What should we do to improve next year, inshallah, and what can we do to get you more exposure to the knowledge and the expertise of our guest speakers. So we started the first day actually with one new things that we did in our conference, which is the workshops. And the feedbacks, we have 3 workshops, one about non-invasive surfactant administration, and one about the neonatal head ultrasound and neonatal lung ultrasound. The feedback that we have is overwhelming, actually, was very positive. So inshallah, for next year, we will have more workshops as a full day. Yesterday was a very exciting day for us. We started the day with innovation session, and we have one GI session, and we finished the day with a neurology session. So today we will continue, inshallah, with the really cutting-edge neonatal topics, and we will start with infectious disease sessions to be followed by procedures in an ICU, and we conclude the day with neurology number 2. So I hope that everybody enjoy and benefit from these sessions, and also a reminder that we would like you to interact with the speaker as much as possible. There's 2 microphones in the front here for if you have any questions. And the last session will be a debate and discussion, so we have a lot of time allocated for this. Again, welcome to the conference, and I hope that you enjoy your day. Thank you.
Thank you so much, Dr. Ramani. We would like to inform our delegates who attended last Thursday's May 11 workshop. Your certificates are now available at the on-site registration. So now let's begin with session 5 on infectious diseases. Let me introduce our speakers to the stage. Dr. Taysir Atrak, Chair of Pediatrics, Sheikh Shakbout Medical City, Abu Dhabi, and Dr. Bibian Afogbu, Consultant Neonatologist, Divisional Chief, NICU Corniche Hospital, Abu Dhabi. Dear doctors, the session is yours.
Good morning. We'll go ahead and start with the 5th session. It's an infectious disease session. This session is extremely important. This is one of the areas that we encounter on a daily basis, and we have lots of challenges making the decision. We try to rely on clinical practice guidelines from UK, from US. We try to have our own guidelines, our own hospital. But in the end of the day, it is the physician judgment, our judgment that will count, putting everything together and looking at the circumstances. So I'll go ahead and introduce our speaker, Dr. Hakam Yassin. Dr. Hakam is the professor of pediatrics as well as the head of pediatric and neonatal unit at Sharjah Hospital, University of Sharjah. Also, he is the chief medical officer at the hospital. He will talk to us about the management of early onset sepsis. Please join me welcoming Dr. Yassin.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everybody. Thank you very much, my dear Dr. Taysir, for the kind introduction. I would like also to thank both Dr. Ayman and Dr. Junaid for inviting me to this excellent conference. It is the best conference in UAE in neonatology, as I usually said, and it's true. And it's very well organized. Topic are excellent. Speakers, selection of speakers. So thank you very much. So let me start management of neonatal early onset. So we are speaking about early onset, and I will discuss the guidelines in early neonatal sepsis, comparing between the American, North America, American Academy of Pediatrics, and the NICE guidelines. So the UK versus the American. And as you know, the reason behind this presentation is, as you know, UEA is international country, and there is in the same department, you will see a variety of trained neonatologists from mainly, I would say, dominantly from UK and USA, and sometimes even I attended some conflict discussion between both sides. So it is good to know what are they on both sides, and then at the end I will conclude that it is good to have your own, perhaps mixing, as we are in the University Hospital Sharjah, we are doing mixing of both when we see this is good. It should be, your guidelines should be based on one reference at least. When you will be asked why you did this, it is according to this or this. So this is what I prefer. So the NICE guidelines here were updated in April 2021, and the American Academy, the last one was in 2018. We'll start to discuss about the risk factors, about the management, and also about some investigations. So what's the difference? So, for example, for the maternal fever here, the American College of OB/GYN defined isolated maternal fever as any temperature more than 38. So it should be equal or 38. It was before, previously 37.8, but now they fixed on 38 centigrade with no other clinical criteria. Similarly, we mentioned there is a lot of similarity also, not all different. So the current NICE guidelines separate isolate intrapartum fever and chorioamnitis, and also they were 37.8, but now 38. Diagnostic approach. Recent guidelines from AAP and NICE guideline provide updated recommendation on the approach at risk factors, particularly for those who are well appearing at birth. There is no problem for the baby that he has respiratory distress or he has fever. Now we are speaking mainly about well appearing. He is asymptomatic. And it's important to note that the guidelines from AAP are divided into infants more or equal 35 and less than 34 plus 6 days. The NICE guidelines identify preterm birth as a red flag, so they mentioned below 37. That's it. There is no difference. Now again about the update. What are the similarity? We mentioned about the similarity between AAP and NICE guidelines. So both guidelines recommend intrapartum treatment for prevention of early GBS. So there is agreement between both. Both identify similar risk factors for early onset sepsis. Neither strategy will identify infected infant with precision, as usual, and neither strategy avoid treating substantial number of infants who are infected. Again, both guidelines recognize the importance of repeated observation in infant with risk factor for sepsis, and both recommend stopping antibiotics as 36-48. Now you know the blood culture, it came by 24 to after 12 hours. When the new machines of blood culture, they give alarming after 12 hours, and by 36 hours you will know if there is infection or not in 90%. So when to start antibiotics? Let's start the guidelines mentioning when to start antibiotics in a baby who has some risk factors. The NICE guidelines uses red flags and other non-red flags factors to identify which infant required sepsis evaluation and treatment. In babies with one red flag or 2 or more non-red flag risk factor, the recommendation is to start antibiotics as soon as possible. And as I mentioned, within 48 hours, it can be stopped. What are these red flags? So, IV antibiotics treatment given to the mother for confirmed or suspected infection, chorioamnionitis, prematurity, suspected or confirmed infection, and another baby in the case of multiple pregnancy, respiratory distress starting more than 4 hours, seizures, and need for mechanical ventilation in term baby, and the last is sign of shock. So now here, without red flag, rupture of membrane more than 80 hours in preterm birth, unexplained jaundice, early jaundice, 24 hours, need for CPR, oliguria, metabolic acidosis, hypoglycemia, apnea, and again, maternal fever, which is previously was in the red flag, but now they put it non-red flag. So a commentary in this, that in babies without any red flag and only one risk factor, a clinical indicators, clinical judgment should be used. So for example, if you have only one non-red flag, of course, it's not a black and white, don't treat. You can, of course, judge and treat if needed. If an infant is not treated, the NICE guidelines recommend observation for 12 hours they have criteria for newborn early warning system. Our nurses, they know what are these early warning systems. So they are observing for 12 hours, and if not, they release. And this is 12 hours of observation, this is a commentary, is probably not sufficient. And the NICE guideline has not been compared with the sepsis calculator. 12 hours, why? Also because in UK, they are usually keeping the mother for 12 hours and then not for 24 hours like here, 12 hours, and then they discharge home. But there is follow-up. The difference that it was raised yesterday also. You should be careful because in UK, after 12 hours, there is a midwife. She will go and visit the mother and about the jaundice, about all the other risks. But here, the mother will be alone, with the grandmother perhaps. Now, when to start antibiotics according to the AAP. So we finished the when to start in NICE guidelines, and now about in the American Academy. The American Academy of Pediatrics guidelines offer 3 alternative strategies for the management of infants with suspected sepsis. Again, we are speaking about asymptomatic. Categorical risk assessment. This is the categorical risk assessment. This is like before. It means that they are based, still not neglected, but it is there. And there is some colleagues, according to the survey, they are following this. Sepsis calculator, and this is a lot of American centers, they are using the sepsis calculator. And there is a third one, the serial clinical observation. So they don't calculate the sepsis factor, but they have clinical observation, and it is difficult. And as you mentioned, because it's in the first 1 hour, then 2 hours, then 3 hours, continuously observation. So it's feasible or not. This is also an issue. The sepsis calculator is the most used in USA as per the publications. And sepsis calculator estimates early onset risk factor using a regression model that includes the following: categorical and continuous variable, GBS status, maternal intrapartum antibiotic therapy, maternal fever, gestational age, and the prolonged rupture of membrane. And then the risk sepsis per 1,000 per live birth is further quantified with consideration of the infant clinical condition after birth, classified as well-appearing, asymptomatic, equivocal, borderline, or clinical illness. Empirical antibiotic is for infant with an estimated risk sepsis of more than 3 per thousand. So this is, I put it from, this is the app that they are using. And as I mentioned, all you will complete it here. And then this is an example. The incidence 0.5 per thousand by CDC recommendation. The baby is 36 weeks, and maternal fever 38, prolonged rupture membrane of 18, GBS mother positive, and type of intrapartum started more than 4 hours prior the delivery. And this is the result here. It come as if he is well appearing 0.55, so they will not rate. If there is borderline, they will treat, and this is the calculation. And this is the result here it will be. If well appearing, no culture, no antibiotics. If equivocal, they will start, and if there is signs, they will start on time. It's not easy, so you should have it's not difficult, sorry. So you will have the calculator and you can follow it. Sepsis calculator meta-analysis studies of moderate quality evidence indicate that the implementation of sepsis calculator was associated with reduced usage of antibiotics, laboratory tests, and admission to neonatal unit, and no increase in mortality. And this is in recent publications. Again, this is in 2022, Australian study. They wanted to evaluate again the calculator and then to determine if any case of culture positive neonatal early onset. Then they conclude that the significantly higher rate of missed case using the neonatal sepsis calculator compared with current guidelines and practice support the concern of many neonatologists regarding the safety of the neonatal early onset sepsis calculator. And this is new in the Australian study. So there is still controversiality about this. So the commentary for the American Academy of Pediatric use of sepsis calculator misses a substantial proportion of infants with early onset, and this is also discussed here. Sepsis calculator versus serial clinical observation, this is the second and the two. So this is the concept of serial examination provide a system of structured exam and vital signs monitoring through the first 48 hours of life for well appearing. And you remember that if in the American Academy, they mentioned it from the previous guidelines, if the mother GBS positive, keep the baby for 48 hours for observation. And this is the part of it. And the frequency of exam should be highest in the first 24 hours, which correlate with the timing of presentation of most infant. They will have clinical signs. The committee on fetus and newborn recommend the serial clinical observation approach as an alternative to the use of sepsis calculator. However, there are significantly fewer reports of successful implementation of the serial clinical observation strategy. Using this approach, several investigators have reported significant reduction in both antibiotics exposure and lab testing. Effect of maternal intrapartum antibiotics prophylaxis. Here, most commonly used ampicillin, penicillin for the mother, and cefazolin, and this antibiotics reach blood level above the minimum inhibitory concentration, meaning that it is very effective. So both AAP and NICE guidelines agree that antibiotics can safely be discontinued within 48 hours. CRP and procalcitonin, the CRP and procalcitonin have been evaluated, and there is little benefit in obtaining early CRP level for the CRP. So no benefit to do it in the first 12 hours. However, it was found the usefulness of single CRP measurement at 18 hours in unit. What I'm telling you, what we are doing in our unit, we are, because most of these babies that they are in risk and you cannot observe them for 48 hours because of mainly for the insurance, they refuse to keep, and the parents. So we are doing in our unit two series of CBC CRP at after 12 hours, 24 and 36 hours before discharge, 24 to 36 hours. And if it's both are negative and baby is well appearing, usually the predictive negative value is around 99%. So you are in the safe area. So procalcitonin versus versus procalcitonin meta-analysis. So there in this meta-analysis, they have the procalcitonin, CRP, and both, and they want to see how much the sensitivity. A total of 28 studies, which is a very strong study, good study, were included in the meta-analysis, and the pooled sensitivity of CRP was 71%. So you have around 29% negative, false negative, and was weaker than the procalcitonin, which is 0.85%. When they do it together, procalcitonin and CRP, the sensitivity is 91%. So meta-analysis and systematic review found that the recombination of procalcitonin and CRP is good indicator. If serial CRP values remain normal, there is a low likelihood of infection with negative predictive value of nearly 100%. And again, I know that the AAP, they don't based on CRP as we mentioned here. So the NICE guideline 2021 recommend the serial CRP determination to decide on the duration of antibiotic treatment, while the AAP guidelines do not make that recommendation. And I heard from some colleagues, even if I have CRP normal 40, I will discharge the baby. And of course, this is, in my opinion, this is an extreme also. Management of guidelines based in GA and AAP, the NICE guidelines address the management of both term and preterm infants, whereas the AAP published separation, as we mentioned before, and NICE guidelines are likely to be superior in identifying a symptomatic infant with early onset at the moment of birth, but result greater use of antibiotic than the sepsis calculator. The major difference here that NICE guidelines are adjunct laboratory testing, CBC, CRP, blood culture, to make clinical decision and to determine the duration of treatment, while AAP sepsis guidelines state that evaluation of inflammatory markers should not determine which infant need antibiotics. Again, NICE guidelines offer the sepsis risk calculator as an alternative strategy, but only in the context of research audit project. AAP recommends the sepsis calculator as one of three principal strategies. Now, lumbar puncture. Again, there is some controversiality. NICE guidelines are more liberal with their indications for LP and recommend lumbar puncture there. Even there is strong clinical suspicion of neonatal sepsis. They are doing liberally, I would say. And even one of the authority, when I discussed with him, he told me, Hakam, this is like a cannula, IV cannula, so no problem. So this is Neil Marlowe, if you know him. American Academy guidelines recommend a lumbar puncture in infants with positive blood culture or clinical illness. So they are more restricted, and we discussed one time to do or not to do, and we discussed the American Academy views in this about the lumbar puncture. Choice of antibiotics, NICE guideline, they are using penicillin and gentamicin, and the American Academy use ampicillin and gentamicin because of the listeria. Again, the listeria here, how much you see. I remember that I asked Professor Pollen, I asked him how many cases you saw listeria. He told me over 30 years, I haven't seen a single case. So this is, I don't know for your experience, but this is my experience. So very, very, very rare. I saw one case, it was in France with meningitis. Management guidelines here, according to the AAP, while CRP procrastination can certainly provide a reassurance for the discontinuation of antibiotics, there is little evidence to continue antibiotics purely based in the CRP when the blood culture remain negative. So I will conclude here. The primary aims of the AAP and NICE guidelines are to identify infected infants with precision and to minimize the use of antibiotics in infants who are uninfected. The guidelines from AAP, as we mentioned, that they are dividing the preterm below 35 and more than 35 weeks. NICE guidelines, the preterm, regardless of the gestational age, is a red flag. The American Academy is more in favor of adopting sepsis calculator and serial clinical observation. The decision was not to treat, if the decision is not to treat, the NICE guidelines recommend observation for 12 hours using the early warning system compared with the serial clinical observation for 48 hours. And this is my opinion. There is strong evidence that if you want to observe, it should be 48 hours, not 12 hours. Sepsis calculator recommended by the AAP misses a substantial proportion of infants with early onset. NICE guideline does not adopt it in the routine guidelines. If a blood culture negative in well-appearing infants, NICE guidelines and AAP would recommend to stop antibiotics early, although the stopping criteria are a little different. CRP marker is more interested by the NICE guideline. Before last slide, for blood culture obtaining 1 ml, not 0.5, and poor sensitivity of white blood cells and different count in detecting sepsis in first 24 hours. The 2021 NICE guidelines recommend the use of serial CRP determination to decide on duration of antibiotics, while the Academy Guide do not make that recommendation. And for lumbar puncture, more liberal in the NICE guidelines and restricted in the American Academy. The last slide here, the choice for empirical antibiotics differs between UK and USA, and this is the last slide. Each unit, and this is mentioned by both, each unit must individualize their approach to early onset sepsis based on the neonatal population they serve and available resources. And this is both of them, they mentioned that. So you should have your own guidelines and consider that you are not in America and you are not in UK. This is so should be reserved about the way to discharge the baby in a safe situation. Thank you.
Thank you, Professor Yassin. Very interesting, and as you said at the beginning of the presentation, this is our day-to-day, everyday challenge with sepsis. One of our things that we also look at is the antibiograms, which also would influence local practice and they help you to delineate what antibiotics choices you may have. So this is a good follow-on talk coming from one of my colleagues, and he's going to be talking about the management of babies born to mothers with chorioamnitis. And as you heard from Professor Yassin, that's one of the red flags that we look at to determine when and how much we treat babies. So Dr. Ibrahim is one of my colleagues from Cornish Hospital, and he has an inherent passion for infection, and actually he's our chair of the Hospital Infection Committee at Cornish Hospital. He has other passions as well, but he's here today to talk to us about sepsis and the role of changing things around maternal chorioamnitis. Welcome, Dr. Hafiz. Thank you.
Assalamu alaikum, good morning. Thank you, Bibian, for the kind introduction, and thank you, Dr. Ayman and Dr. Junaid, for inviting me to talk here. It's indeed a privilege to be speaking amongst such a distinguished set of speakers and also to speak to all of you who've come from UAE and beyond. So it's a slightly different tack, but very similar, so there'll be a bit of overlap with what Professor Yassin has said. This morning, I'm going to be talking about the management of infants born to mothers with chorioamnitis. It was a very important categorical risk factor when people started formulating guidelines for management of early onset sepsis right from the late 80s and 90s. We'll just have a look through the course of this talk as to how things have evolved and whether it carries the same weight as when the guidelines were originally formulated. At the outset, I've got no disclosures to make, and our hospital breastfeeding BHFI leader said I have to disclose that I have no sponsorship from milk companies, which I don't. So, as Professor Yassin mentioned, early onset sepsis remains an important cause of early neonatal mortality and morbidity. And I think Professor Brownwall will be talking about it later on long-term outcomes, and I'm not going to dwell upon that now. So the reality of the matter is the incidence of early onset sepsis in the middle and high-income countries have been dropping significantly over the past many years, partly because of improved antenatal care and, of course, the universal screening for GBS and prophylaxis. So if you look at the graphs in the US, you can see when the first statements were made in the early 90s, it was as high as 2 per 1,000 live births, which is in the early 2000s, it dropped to around 0.5 to 0.6 and has remained there. I looked at our data at the Cornish, and it's very similar. We started universal screening probably in 2012 to 2013, and when I looked at 6 years' worth of data, ours is almost similar to what the CDC is saying, between 0.4 and 0.5 for the more mature babies. We know that chorioamnitis is an important risk factor, but experts in this area have been questioning, is the risk the same in the era of GBS screening and with falling early onset sepsis rates? And is it time to look at alternative approaches, some of which Professor Yassin has already discussed? Now, when we speak about chorioamnitis, it's a pretty broad term. It's a term used to denote the inflammation of fetal membranes. It doesn't necessarily mean infection, it's inflammation. And when you look at the incidence, which is reported from the US from various papers, it varies anywhere from 1 to 10%. This kind of highlights the ambiguity around this diagnosis. Because like Professor Yassin mentioned, very often it's purely based on maternal fever, and we call it chorioamnitis. But true chorioamnitis is actually associated with adverse both maternal and neonatal outcomes. Mothers can become quite sick, septic, they can have uterine infections, scar infections after cesarean. Neonatal outcome, apart from early onset sepsis, especially in the preterm group, they can be associated with a lot of short and long-term adverse outcomes, which I'll touch upon later. So as I said in the past, inflammation was always associated with infection, which probably is not the case. Now, what about the microbes in chorioamnitis? When we talk about infective chorioamnitis, the gold standard has always been the isolation of a bacterium from the amniotic fluid or the membranes. But when you look at how many of these actually proven chorioamnitis do have bugs, when you look at term infants, it's around only 12%. The detection rate is slightly higher when you use molecular methods, and in preterms, it's 3 times higher. So for the purpose of today's talk, I'll be mainly concentrating on the more mature babies where the risk is low. In preterms, as Professor Yassin said, the AAP itself has divided the guidelines into before 35 weeks and about 35 weeks for exactly the same reason, because the risk is much higher in preterm infants. And then the concepts have been changing. We've always thought the uterus is a sterile environment. And people have been questioning that wisdom now. These days, we cannot go anywhere without hearing about our microbiome, which is part and parcel of our being. And they say even before we are born, we do have a microbiome, but again, the jury is out what is true, but the concepts are changing. And as I said, inflammation is not equal to infection. So there can be sterile inflammation in the membranes without a bug being there, exposure to toxins, exposure to maternal inflammatory conditions, even viruses, which won't do anything, which the antibiotics we use won't do anything for. And when people have looked at the membranes and placenta of preterm births, and they've found there can be histological chorioamnitis without any symptoms. And on the other side of the coin, histological chorioamnitis without infection can present exactly like an infection. Mother can be ill, can present with fever. So it's very difficult to differentiate. So this brings us to what's clinical chorioamnitis. In practice, it's a diagnosis based on clinical features in the mother. We don't have cultures, and nobody is going to do an amniocentesis to diagnose chorioamnitis. So very often it's based on what the mother presents with. And in reality, what happens is very often it's based on maternal pyrexia alone, despite all the attempts by neonatologists and obstetricians to kind of pin down the exact criteria. But even those criteria, the sensitivity and specificity is poor. So the consequence is, if there is suspicion, mother gets treated with antibiotics. And the moment we hear that, we neonatologists, we lose our marbles and the babies get antibiotics. Soon after graduation, more than 30 years ago, I used to be very happy prescribing antibiotics. But these days, every time I kind of click on my mouse or take a prescription, I always wonder, do we actually really need to use it? These, yes, when used in the right situations, they are life-saving drugs, but used wrongly, they have a lot of long-term adverse effects. So because of this, the NICHT had put together a group of neonatologists and obstetricians more than now nearly 8 years ago to say, what is actually intrauterine inflammation? They came with this concept of triple I. That's intrauterine inflammation or infection or both. So like in the guidelines, maternal fever alone is not a criteria for chorioamnitis, but very often if I look at my hospital records in my hospital, a lot of the diagnosis is based purely on that. So you need to have at least one of the following. It's fetal tachycardia. Maternal tachycardia has been taken out. So anybody with a fever will have tachycardia. Or maternal white cell count more than 15,000. Yes or no, it's neither here nor there. And a purulent cervical discharge. In the past, they used to say foul-smelling discharge. What's foul-smelling to me may not be foul-smelling to you. That's the thing. So you need to actually see pus to call it chorioamnitis. And the definite diagnosis is biochemical or microbiological evidence of infection in the amniotic fluid. We are not going to get that before the baby is born, so that's a moot point. So it is a clinical criteria which we should be using. In reality, how many people use this? Very few. So I'll briefly touch upon what chorioamnitis does to our babies even before they're born. So the moment inflammation sets in, infections or otherwise, there's an inflammatory storm happening around the baby. And this kind of induces preterm labor, rupture of membranes, as the babies are born preterm. Apart from early onset sepsis, even if they're not infected, it sets them up for other inflammatory conditions that increase risk of NEC, ROP, BPD, and even brain damage. And now they're thinking that this inflammation sets off epigenetic changes in these babies, and in the long term, they can have reactive airway disease, adverse neurodevelopmental outcome. But what we're interested is chorioamnitis in the context of early onset sepsis. So the neonatal management has always been based on quantifying the risk of vertical transmission of infection from mother to baby in these babies. And the past guidelines have always said the presence of chorioamnitis alone was a significant risk factor. So you jump on the baby, screen the baby, start antibiotics. And the previous AP and CDC and NICE guidelines all supported this, and to a certain extent even now. So the consequence, a large number of well infants are still being treated with antibiotics. So if you look at quantifying the risk, it's unequivocal that chorioamnitis does increase the risk of early onset sepsis. There's a meta-analysis recently published by Goldstein's group. So in the preterms, in the whole population, and in late preterms, the risk is definitely there. But what is the actual risk of early onset sepsis after exposure to chorioamnitis? If you take the whole population, preterm and term, it's around 3%. Preterms, as I said, is 3 times higher because they have a 3 times higher risk of exposure to bugs. But if you look at the actual incidence in late preterms and terms, it's less than 1%. So for 100 babies we treat, probably we're targeting that less than half a baby, or 1 in 200 babies who might actually benefit from it. And people have tried to look at this objectively. So the number needed to actually treat an early onset sepsis in this context is as high as 450. So to capture one early onset sepsis in this group of babies, you might be treating hundreds of babies who actually don't have infection. In the preterm, there's a different story. The risk is higher, the number needed to treat is much lower, much better than many of the therapies we use, so we won't even go there. So if there is chorioamnitis suspicion, and you have a preterm baby, don't faff around. Start antibiotics and wait for the septic markers and cultures. So this is just summarizing what was in the old guidelines. So if you have chorioamnitis, you got antibiotics when you're a baby, regardless of your gestation. So the problems of using chorioamnitis as a categorical risk factor is manifold. So the first thing is a poor definition of chorioamnitis in mothers, which leads us to use of antibiotics. And in the era of GBS screening, does chorioamnitis carry the same weight as a risk factor for causing early onset sepsis? And there's unnecessary exposure of a lot of low-risk infants to antibiotics. The short-term consequences, the babies get separated from their mothers, they stay in the hospital longer, and we know it alters the microbiome. Once you alter a newborn's microbiome by giving them broad-spectrum antibiotics, it takes months and if not years for it to come back to normal, and this translates to long-term outcomes in terms of autoimmune diseases, how their gut functions in the future. So antibiotics are not to be trifled with. And of course, by overuse of antibiotics, we are fostering resistance and plummeting towards an antibiotic apocalypse. There's not that many antibiotics coming out of the pipeline at the rate which we are losing to these bugs. The bugs are getting more intelligent and resistant, especially in this part of the world. Some of gram-negatives, it's as high as 20% ESBL, 30% MRSA of all staph aureus isolates. So we have to be very judicious with the use of these drugs. So even before the new guidelines came out, as early as in the early 2000s, people were asking, is a risk factor-based approach for well-mature babies redundant? And the answer is probably, because when people looked at babies who were treated with antibiotics, thousands of them, about 35 weeks, were treated with antibiotics. The risk of actual infection was probably 1 in 1,600 babies. So people have been asking, is it time for an alternative approach? So I'm going to summarize a few studies to get to my point. So this was a study published from Utah in 2015, where they looked at a significant number of babies, more than 34 weeks, were exposed to a clinical diagnosis of maternal chorioamnitis, not just histological. And you can see even at that time, people were sitting on the fence. Only 65% actually followed the AAP guidelines and gave these babies antibiotics. And of the babies who got antibiotics, only there was one case of GBS. So their sepsis rate was pretty low, and 22 infants were treated for culture-negative sepsis, either based on inflammatory markers or clinician discretion. So still less than a 1% incidence in chorioamnitis. So they said, what if we apply the sepsis calculator retrospectively to this group of patients? They said they could actually reduce the antibiotic use to less than 5% of the infants who would have actually got antibiotics. So yes, the sepsis calculator can reduce your antibiotic use. I'm not going to dwell on it. It's been already addressed in the previous talk, so I'll skip this slide. So this is a more recent study, similar methodology. They looked at around 1,200 infants, and they again had a very low incidence of true early onset sepsis in this group. And out of the 5 culture-positive early onset sepsis, the sepsis calculator would have recommended starting antibiotics, only 3 of them in the first instance. But the corollary to that, when you use a sepsis calculator, you need to continue to observe these infants, and they would have been picked up later and treated. So people have been experimenting with alternative approaches, which is kind of dwelt upon in the new AAP guidelines. So this is Professor Ramnathan's group from California again. So they looked at 6 years worth of data. There were around 364 infants who were exposed to clinical chorioamnitis. A third of them were symptomatic at birth, which is quite a high number if you ask me, but maybe the population is different, and they were directly admitted to NICU. The 2/3, around 240, they observed. So they had a very strict protocol. So you did 4-hourly observations, you did CRPs and CBCs at 0 to 6 hours, 12 to 24, and again between 24 and 48 hours, quite intensive monitoring. And out of those, another third ended up on NICU because of various reasons, either symptoms or abnormal septic markers and got antibiotics. But the remaining 2/3 managed to avoid antibiotics. So there are alternative ways of doing this. Similarly, another Californian unit did the same. but less intense blood monitoring. So they did a CBC, so they didn't use CRP at all. And the Americans don't believe in CRP, so they looked at the immature to mature ratio and a blood culture at admission, and they didn't repeat it if the initial CBC was normal. And the observation, as the AP says, was for observation in hospital for 48 hours. So what they did this as a quality improvement project, and you can see clearly what they achieved. So as soon as they implemented this, there was a lot of work which went on before that, educating the neonatologists, the nurses, the midwives to closely observe these infants. The use of antibiotics plummeted and remained low. And the good thing they found is none of the babies actually were missed. Some of them became symptomatic later, which they treated, and none of the babies came back later to hospital admitting with missed sepsis. Another unit in California did the same, exactly same findings, and they hadn't encountered any problems. Slightly different approach from another group in the US. They didn't do any bloods at all. They just observed them. So again, a good number of babies, around 310 of them were exposed to chorioamnitis. 10% of them were symptomatic or had other issues, so got antibiotics, and the rest they observed. And based on observation, again, another 10% developed symptoms and were started on antibiotics. The others were observed without any lab monitoring, which some of us might become nervous about, and they remained well, and they were discharged, and there were no readmissions or any adverse outcomes in those infants. And they could achieve a 55% reduction in antibiotic use. So, like Professor Yassin mentioned, there are three approaches which AAP recommends. One is the categorical risk assessment, which some people are still fond of, but I think it's probably time we started moving away from some of it, especially in this context of chorioamnitis. You can use a sepsis calculator. It might miss some of the sepsis early on, but it will capture them early on if you have close observation. So sepsis calculator cannot be used on its own. The important fact is training, close observation. And we shouldn't forget clinical medicine. These days we become so reliant on technology and labs, we forget to look at the baby. The baby should be looked at very closely. And the third approach, which is enhanced observation, which I think might reduce the antibiotic use even further. So the summary of current evidence, the first thing to say is early onset sepsis is really low these days in the era of GBS prophylaxis, and at least on our unit, it's around the same as in the US, and I'm sure in large units like Tavam, it's probably the same, and in SSMC as well. And majority of late preterm and term infants with maternal chorioamnitis who are well at birth will remain well. So is it fair to expose all these babies to antibiotics? There will be a trade-off. Some babies will be exposed, whichever method we use. So we can either use a sepsis calculator, which will reduce the antibiotic use, or serial observations with or without lab markers. And with either of the above three approaches, there's no increase in neonatal morbidity or mortality. So having reviewed the evidence, this is what I would recommend. So if there is maternal chorioamnitis, the first thing is to define what it is. That needs educating our obstetricians, our midwives. Any fever is not chorioamnitis. It could be an upper respiratory tract infections. We use epidurals a lot. Just giving an epidural to a mom can cause fever in the mom. And then you look at the gestation. Babies less than 35 weeks, don't faff around. Screen them, start antibiotics. More than 35 weeks, if they're symptomatic, again, go straight ahead. But if they're not, you can closely observe them with or without lab parameters. If you ask me personally, I would probably want some lab parameters in them because we can miss some of these. And if they develop symptoms of abnormal labs, you treat them. If they remain well, leave them alone. But the caveats for introducing anything new like this, either sepsis calculator or enhanced observation, moving away from a categorical risk factors, you need to know a few things. You need to know your background rate of EOS, early onset sepsis. You can't take something from another unit or another region or even the US and plonk it onto a sepsis calculator. And that's probably why the sepsis calculator goes wrong in many areas. You need to use your own data. And to be aware that either approach, either with using a calculator or enhanced observation, you're going to miss some of them. But with close observation, probably you'll catch them before they go home. So I completely agree with Professor Yassin. Sending them home at 12 hours is not something which I would do, especially in this context, and especially in our context, where we don't have community health care, where there can be close observation. Even in the UK, it's not very close observation if they go home. They get a visit the next day. So there'll be a good 12 or even 24 hours where the baby is not observed at all. So at least 24 to 48 hours, we should be observing them. And if you implement something like this, you have to look at what your manpower implications are. We don't, in many hospitals in this region, we don't have the same nursing to infant ratios we have in the West or some of the more developed health economies. So it is a lot of work for our nurses. So they need training to look at what does a sick infant look like, how frequently should you be doing observations. And Dr. Paulin's commentary, once they said, are they actually doing it? You might actually get on the chart that there are observations, but were they actually done? All these are things to consider, because sometimes they have 6 babies to look after, and will they get the opportunity to go to this baby every couple of hours in the first few hours? Some babies end up getting admitted on the neonatal unit in some places just for that. And of course, you need buy-in from all stakeholders, from the obstetricians, the midwives, and neonatal nurses to implement something like that. So I'll conclude my talk. In conclusion, clinical chorioamnionitis as an absolute risk factor probably doesn't carry the same weight as in the past, and it overestimates the risk of neonatal sepsis. And either the use of a multivariate risk factor approach, aka the sepsis calculator, or an enhanced observation can significantly reduce the use of antibiotics on our units. And we should be tailoring this to our local circumstances based on consensus. Both the American and British guidelines say that anything related to sepsis, look at what you can achieve locally. Don't just plonk something which is used elsewhere on your unit without much thought. And if you change anything, you need to monitor it. So you do audits, look at your data periodically, look at any missed cases, which might kind of help you tailor what you're doing locally. And those are my references, and thank you.
Thank you, Dr. Ibrahim, for this great presentation, and also thank you, Dr. Hakim Yassin. Both, gave us a very nice review and overview of the guidelines from UK and US. And as mentioned, they're a great reference, but we have to look at our own environment and data and resources and follow our clinical judgment. So that's the most important message we should get. Our next speaker is Dr. Eric Eichenwald. Dr. Eric is the professor of pediatrics at University of Pennsylvania. He also the chief of neonatology at Children's Hospital of Philadelphia. He will be speaking to us about the long-term outcome of neonatal sepsis. Please join me welcoming Dr. Eric.
Well, thank you very much. It's been a real pleasure to be here, and I've learned a lot in the conference yesterday, and it looks like there's another great list of speakers. I will say to the previous 2 speakers, the debate in the United States is exactly the same, and I think you've summarized it extremely well, although I think none of us have the right answers yet. But my talk is going to be a little bit of a frame shift. I'm going to be talking specifically about extremely low birth weight infants as opposed to the previous talk. And I think that the theme here is that sepsis is bad, but I think we need to understand what we're doing with babies who have what we call clinical sepsis with negative blood cultures, and that really is going to be the theme of this talk. And I have no relevant conflicts of interest, and I should say that I am the alternate PI for the Penn CHOP Neonatal Research Network site, and a lot of the data that I'm going to be reporting today are studies from the Neonatal Research Network that I've been fortunate to be included with some of my colleagues who've done the bulk of the work. So I'm just going to start with a common clinical case that I think all neonatologists in the room are familiar with. You're taking care of an extremely preterm infant and was delivered to a mother with unexplained preterm labor, so no chorioamnionitis, just unexplained preterm labor. The baby required intubation, got surfactant therapy, and is hypotensive, requiring pressor support. So, of course, you draw blood cultures and begin therapy with broad-spectrum antibiotics. And then 2 mornings later, the blood culture is sterile, and the infant is now clinically better. and your team at the bedside asks you, how long do you want to continue antibiotic therapy? So you grumble to yourself about how unreliable neonatal blood cultures are and order a 1-week course of antibiotics. So I think the thinking here is, after all, what can be the harm? You just want to keep the infant safe and prevent short and long-term complications. And what I'm going to try to convince you of in the next 20 minutes or so is maybe the folly of some of that approach that I think most of us have used over the past several years, and maybe we should be moving on away from that. And I think when we think about antibiotic exposure in the NICU, and I'm really talking specifically about extremely preterm infants, it's obvious, I think, that to everyone, that treatment of culture-confirmed bacterial infection is clearly of benefit to the infant. But it's common practice, as I summarized in that case, to administer antibiotics to preterm infants in the absence of culture-confirmed infection. And I think that this is based on 3 assumptions. The first is that blood cultures are not always reliable, and so you could have false negative cultures due to prior antibiotic exposure, particularly of the mother, or they may be negative in light of critical illness. And we can have a conversation at the question and answer period about blood cultures and whether they're reliable or not. And I think that we also assume that the risks associated with antibiotic use is predictable and manageable, such as drug toxicities when we monitor gentamicin levels, for example, and of course the need for IV access. And I think the third assumption is that antibiotic use, even in the absence of a known organism or positive blood cultures, has significant benefits to the individual infant with what we call culture-negative sepsis. And what that results in, because we all treat babies differently, is this is a summary of work from Dustin Flannery from our organization that has looked at the percentage of infants who receive antibiotics in the first 3 days of life, and then in the lower panels, the percentage of infants receiving antibiotics for more than 5 days. And you can see that there's just enormous variability. These are hospitals in the United States, but just in this lower panel here, this is the percentage of ELBW infants receiving antibiotics for more than 5 days for early onset sepsis. And you can see this significant variability, which I think whenever you see this degree of variability, it suggests that we really don't know what we're doing. And I think that that probably is the case. So let's try to answer some additional questions about early onset neonatal sepsis. And I'll start with the premise that I have outlined before, that antibiotic use, even in the absence of a positive blood culture, has significant benefits to the individual infant with early onset, quote-unquote, culture-negative sepsis. So the questions are, is it true that early prolonged antibiotic therapy for the extremely low birth weight infant treated for culture-negative sepsis improves outcomes? And we know that there's wide site variation, as I showed you, in prolonged antibiotic use when blood cultures are negative. And so the question that my colleagues attempted to answer, are the outcomes of similarly ill infants managed with different antibiotic regimens different? So this was a study that was published a couple of years ago from data from the Neonatal Research Network. It was a retrospective studies of ELBW infants who were either diagnosed with early onset sepsis or were treated with antibiotics for more than 5 days with negative blood cultures. And there were some exclusions, which included if they died before 12 hours or they had necrotizing enterocolitis or spontaneous intestinal perforation at less than 3 days of age. And the primary outcome was the composite of death or neurodevelopmental impairment at 2 years. And what was done was they used propensity scoring, and Dr. Jensen talked about this yesterday, as a way to match babies who were similarly ill. So you took a variety of characteristics and attempted to match babies who had the same degree of illness. And then we looked at babies who were treated with or not with prolonged antibiotics, trying to match the babies to the degree of illness. And so in what the comparisons were, and you can see it here in the circles, is that we compared early onset sepsis cases to babies who received prolonged antibiotics and babies who did not receive prolonged antibiotics. And then there was propensity scoring where we were able to match a little over 2,100 babies in each group. And you can see here that the propensity score matching was pretty tight. The blue color there reflects the babies who received prolonged antibiotics, and the salmon color is that did not receive prolonged antibiotics. And you can see that there's significant overlap, and this is really just saying that the propensity matching worked pretty well in matching babies who were similar degrees of illness. And so what was found was that first, and not surprising, I think, to any neonatologist, is that early onset sepsis results in a higher mortality as well as higher degree of neurodevelopmental impairment. And here, the blue bars represent babies with sepsis, the orange bars, babies who received prolonged antibiotics but did not have positive cultures, and the purple bars are babies who did not receive prolonged antibiotics. And what you can see is that the incidence of death and neurodevelopmental impairment was significantly higher in babies who had true sepsis, whereas there were really no differences between the babies who received prolonged antibiotics and babies who did not. And when they looked at the propensity scores of trying to compare babies of similar illness, there was clearly no benefit of prolonged antibiotics in the matched infants. And you can see here that there was no difference in death or NDI, no difference in death alone, and no significant difference in neurodevelopmental impairment. So it certainly suggests that antibiotics in babies who are ill with negative blood cultures are not affecting outcome, which I think dispels the assumption that we're treating babies to make them better in some way. So in summary from this study is that ELBW infants with culture-confirmed sepsis have a higher mortality or survival with neurodevelopmental impairment compared to both infants treated with prolonged antibiotics or a shorter course, and administration of prolonged antibiotics for culture-negative sepsis was not associated with improved outcomes. And I think that the absence of benefit of prolonged antibiotics, counter to what I presented as conventional wisdom, certainly suggests that there are some further opportunities as we think forward for antibiotic stewardship, particularly in this population. So I'll veer a little bit and ask the question, can we identify a group of extremely preterm infants who are at lower risk of early onset sepsis and therefore avoid empiric antibiotics? And this is an opportunity for antibiotic stewardship, which I think all of us are attempting to do in our NICUs. And so we know from the two previous presentations that premature infants are at the highest risk of early onset sepsis, and most premature babies are treated with empiric antibiotics because of that risk. And we also know, as was mentioned previously, that the pathogenesis of early onset sepsis is primarily through ascending infection into the uterine cavity. So the question is, are extremely preterm infants who are delivered for maternal indications, meaning that they are a cesarean section without labor, the membranes are intact at delivery, and there's no clinical evidence for chorioamnionitis, are those babies at lower risk for sepsis? And if so, can they be safely managed without antibiotics? In this study, again from the Neonatal Research Network by my colleague Karen Popolo, who also is the author of the Neonatal Sepsis Risk Calculator, I really did demonstrate that there is a lower risk with these delivery circumstances. When you take a comparison group of infants who did not have those factors compared to babies who did, you can see that there's a markedly decreased risk of sepsis in the babies who had no significant risk factors at the time of birth. It's not zero, not surprisingly, but it's extremely low. And when you look at variation of what happens across the Neonatal Research Network, you can see in the upper panel there, that's the low-risk cohort that I described, you can see the significant variability across the neonatal research network of babies who received prolonged antibiotics, despite the fact that they had no significant risk factors for sepsis. And the incidence of sepsis in that population is extremely low, as you can see by the black bars. And so the number of infants who are given prolonged antibiotics per early onset sepsis in the low risk category is 66 versus in the higher risk category 19. So I think we can argue that perhaps treating 66 very small babies with antibiotics to catch the one may or may not be appropriate, but that's, I think, something for us to think about and to debate. So let's shift gears and let's talk about late onset sepsis as well and look at their outcomes as well as the use of empiric antibiotics. So this was another study that I had the benefit of being involved in. This was an NRN study that compared the outcomes of extremely low birth weight infants with confirmed late onset sepsis and those with negative cultures who had prolonged antibiotic treatment. And in this study, mainly due to the criticism of the editors of the journal, the culture negative sepsis was retermed late onset culture negative conditions because utilization of the word culture negative sepsis suggests that we know what the etiology of the illness is. And so the babies that had true sepsis were compared to babies who had this late onset culture negative condition, and then babies who had neither were also compared. And we looked at neurodevelopmental outcomes at 18 to 26 months corrected age. And so again, the three categories of babies were babies with late onset sepsis, which were 786 in the very low boxes there, babies with this, with quote unquote culture negative sepsis, or these late on, the LOCNC were 1601, and then babies who had neither were 1553, so a pretty large sample size. And so I'll just draw, this is a little complicated, but I'll just draw your attention to the three red circles. First, when you compare babies who had late onset sepsis to those who were treated with prolonged antibiotics, you can see that babies with late onset sepsis had a highly significant increased risk of death, but did not have an increased risk of neurodevelopmental impairment, probably because the death rate was so high from late onset sepsis. In the second circle there, when you compare babies who had what again was culture negative sepsis and were treated with antibiotics versus babies who had nothing, you can see that there was no difference in death, but there was an increase in neurodevelopmental impairment. And just to summarize, so what I can say, this late onset culture negative conditions was twice as common as culture confirmed late onset sepsis, which means there are lots of babies who are sick but have negative cultures. There's a higher risk of death in infants with late onset sepsis compared with both this late onset clinical condition as well as the unaffected. And the risk of death did not differ between infants with this late onset clinical condition and those who had nothing. And so what this tells us is that the adjusted relative risk of neurodevelopmental impairment was no different between the late onset sepsis and those that were unaffected, but was higher in babies who had this late onset clinical condition. And so the question I think that this study raises is the etiology of this worse outcome in these babies with culture negative sepsis related to instability, or is it the cause of the instability, or is it actually the antibiotic use? And so there's some suggestion that antibiotics may have some deleterious effect, and so prolonging antibiotics may actually be harmful. And I think this again underscores the importance of understanding babies who have culture negative, what we call culture negative sepsis, and whether prolonged antibiotic therapy may actually worsen outcomes rather than improve them. And one of the things that has come to light recently is that there are these cases of acquired cytomegalovirus in these very preterm babies. And there are many reports now of postnatally acquired CMV in preterm infants. And this is likely acquired through maternal breast milk in mothers who are CMV positive. And this is something that if you don't look for it, you're not going to find it. And outcomes have been described as being fairly variable. This can be asymptomatic, and we're not going to find it unless we look and screen babies for CMV. But it is associated with a longer length of stay, increased risk of BPD, and neurodevelopmental impairment. And the interesting thing is the common reported clinical signs are those that are very, very common to what we call late onset sepsis, including thrombocytopenia and neutropenia, and a sepsis-like syndrome in 30% of babies. And so it may be worthwhile in babies who end up becoming acutely ill, you get evaluated for late onset sepsis, the cultures are negative, in sending screening tests in babies who are receiving maternal breast milk for cytomegalovirus to see if that's a potential cause. Now, whether or not treatment of that is beneficial, I think remains an open question, but it could steer you in a different direction and help you discontinue antibiotics on the earlier side. And so I'm going to close with another NRN study that was just recently published that was looking at the evaluation and outcomes of late onset meningitis. And the first presentation reviewed that there are some debates about when babies should get LPs. And this study was looking specifically at extremely low birth weight infants and looking at the risk of death and neurodevelopmental impairment at 2 years of age, and also was asking the question of what's the incidence of lumbar puncture performance in confirmed late onset sepsis. And what the study found, again, just looking at the population in the Neonatal Research Network, is that the incidence of late onset meningitis in the ELBW has decreased over time. This is looking at 2003 all the way to 2017, and you can see that the incidence has dropped over time. And then when you look at the incidence of death or NDI, it varies by organism. Fungal meningitis is by far the worst. Coag-negative staph as a cause of meningitis is rare, but it is true, and it has the lowest incidence of death. And any other bacteria is somewhere in between. So this meningitis can be very severe and has a very high risk of death or neurodevelopmental impairment. And the other thing that this study found was that when you look at the incidence of late onset sepsis and when lumbar punctures were done, here the bars show the incidence per 100 infants of sepsis, and in the earlier years, LP data was not collected. But you can see that from 2011 to 2017, the proportion of babies who had LPs done despite having positive blood cultures actually decreased across the neonatal network. And it suggests that there's a hesitancy to do LPs in these 6 small babies despite the fact that they have positive blood cultures, which may mean that we're significantly underestimating the cases of meningitis. And it may be that there are cases of meningitis that are unrecognized due to diagnostic practice. So we don't really understand the full association with outcomes because it may be that these are babies that are dying from sepsis who actually have meningitis as a contributor to their death, but because we're not performing LPs, we may not actually know that they have meningitis. So just to summarize some practice implications, I think, from this data, is that both culture-confirmed early and late onset sepsis in the ELBW is associated with a higher risk of death or neurodevelopmental impairment. And that, I think, reinforces the need to prevent infections, particularly late onset infections, which are more common than early onset infections, through our quality improvement methodology that all of us are undertaking across our NICUs. And that's resulted, I think, as I showed the data, a decreased incidence of sepsis, which is great, and also a decreased utilization of antibiotics. This data also suggests that prolonged antibiotic therapy in early onset culture-negative sepsis does not result in improved outcomes. And I think that that is an opportunity for unit-based antibiotic stewardship to try to decrease the utilization of antibiotics in infants who have negative blood cultures. And what we're trying to advocate in our hospitals in Philadelphia is believe the blood culture result. If the blood culture is negative, even if the baby gets better while on antibiotics or remains sick on antibiotics, you should seriously consider stopping the antibiotics if you don't have a positive blood culture. And I think that we should try to move away from this concept of culture-negative sepsis. I think I can say pretty confidently that meningitis in ELBW infants is likely underdiagnosed. And I think under that, I would recommend that lumbar punctures should be part of the evaluation in babies with positive blood cultures. Personally, I do not do lumbar punctures as part of my late onset sepsis evaluations unless I clinically suspect meningitis. But I think if you do have a positive blood culture, even with coag negative staph, I would recommend performing an LP just to rule out the possibility of meningitis. And lastly, this higher risk of neurodevelopmental impairment in ELBW infants treated with prolonged antibiotics for late onset sepsis-like events who have negative blood cultures suggests that we need to understand the etiology of these episodes, what's causing these babies to become more clinically sick that we suspect sepsis, and whether or not antibiotic therapy is actually associated with worse outcomes due to some degree of neurotoxicity in our very vulnerable, extremely low birth weight infants. And with that knowledge, I think it probably is, again, reinforcing the need for us to think seriously about every baby that we're treating that is getting prolonged course of broad-spectrum antibiotics in the setting of negative blood cultures. And I would really advocate for taking a couple of steps back and deciding whether or not treating that child, individual child, is really necessary, given the data that I've shown you that it probably does not have any significant benefit. So with that, I will close, and I look forward to the question and answer period. Thanks for your attention.
Thank you, Dr. Eric. A very stimulating talk indeed. A lot of food for thought for all of us in the room. Lots of new terminology, late onset clinical conditions, change of terminology. So we've had a good morning so far. It's interesting how what we do every day remains a challenge on how to best manage this. But we do know one thing, sepsis is bad, as Dr. Eric has said in his talk. We'll follow on with this session with Dr. Monica Kushal, who is an esteemed neonatologist within the private sector. She works mainly in Dubai, and she'll be speaking to us about things we need to avoid, how to manage septic shock, a situation we'd rather not be in if we look at all the other things that should proceed to prevent sepsis. We welcome Dr. Monica to the stage.
Thank you. Thank you, Dr. Ayman and Dr. Junaid, for a wonderful academic session and for the invite. Okay, so my topic is diagnosis and management of shock, and I would like to take you through more on physiological part of the hypertension and hypoperfusion. We'll review pharmacology of medications, and physiologically, we would like to define the etiologies of hypotension and hypoperfusion and select appropriate medications. So I'll start with a case, term male baby, born to gravida 2 para 1, normal vaginal delivery, cried immediately after birth. Day 3 of life, admitted with lethargy and refusal to feed, and admitted to NICU level 2, started oxygen and antibiotic. Soon the baby became sicker, labored breathing, so shifted to level 3, ventilated, requiring a high ventilator setting and high FiO2 requirement, was mortal bleeding and edematous. So vitals were, SATs were low, blood pressure was 40/32/30, CFT 6 seconds, and pulses poor in all the 4 limbs. Now, how will we manage this hemodynamically devastated infant? For that, the first thing I would pay attention to is, what is the blood pressure low for this baby? Now, how do we define hypertension? Because our treatment would start from there. And from years, we have been looking into mean blood pressure if less than gestational age, or another thing which has come up is less than 30. Along with that, we shouldn't be forgetting about the vital organ hypoperfusion, which would lead to ischemia in the tissue, and cerebral hypoperfusion, which will lead ischemia in the brain and the IVH sometimes. So this is a very different slide where we have looked into the blood pressure of 30 number has come into, and it has been seen even through the NERS and those studies which showed that once your blood pressure is below 30, the autoregulation cutoff point is reached, and you will have a drastic decrease in the cerebral blood flow. And hence the number of 30, irrespective of gestational age, has come into picture. And we must define autoregulatory phase, because going higher than that also increases the cerebral blood flow and may cause IVH, so that's not required. And going below it causes ischemia. Having said that, there are other graphs which are available for 72 hours. They are based on the hours as well as the gestational age, where you can say which blood pressure is okay for that hour and for that age. And these three gentlemen over the wine glasses, they decided one day that mean blood pressure is equal to gestational age, and anything below that is wrong. And we have been following it till now. And then the latest, there is a prospective multicentric study which has given blood pressure according to the different gestation, and we can follow any of these parameters. Having said that, number is not the only thing which we are looking at. We have to look at the clinical sign of the baby of hypoperfusion, which will start from periphery. You may have mottled skin, prolonged capillary refill, cold extremities, and faint pulses, decreased urine output, tachypnea, tachycardia or bradycardia, altered sensorium, and followed by some labs leading on to serum lactate, base deficit, and anion gap problems. So when we look into all these clinical parameters, the capillary refill time has been the most important one, which is correlating to 95% of the times with hypoperfusion, followed by urine output, heart rate. 70% correlation is with the color of the peripheries, base axis, and lactate. 50% is the correlation of pH, movement, activity, and warmth of the toes. And very less, 20% is of value of the hemoglobin. Now, when we talk about blood pressure and perfusion, our main concern is the metabolic homeostasis and the cellular metabolism, which actually weighs between oxygen delivery and oxygen consumption. So oxygen delivery would depend on the hemoglobin, oxygen saturation, and cardiac output. And the hemoglobin would depend on anemia and hemorrhage, and saturation would depend on the lung disease and shunts. The cardiac output depends on the heart rate, preload, afterload, and contractility. And sepsis plays an important role on heart rate, contractility, and sometimes even on the preload and hemoglobin when UDIC starts. And the oxygen consumption, of course, the sepsis would increase the oxygen consumption by increase in work of breathing and fever, and so on and so forth. So perfusion is equal to systemic blood flow, but you must know that we are dealing with a newborn where there would be shunts also playing a role. So right-sided systemic blood flow plus atrial shunt, and the left side systemic blood flow plus ductal shunt has to be taken into consideration. Is systemic blood flow equal to blood pressure? No. There is a poor correlation between the, as you can see in this cartoon, poor correlation in the systemic blood flow increase and the blood pressure increase. This you must keep in mind. And hence the key message from my first part is the mean blood pressure of 30 you have to keep in mind, and you can still take the gestational age and mean blood pressure. The blood pressure is poor correlation with systemic blood flow. They are independent variables. Think of pressure as well as flow for the treatment. Now, what would be the causes of this hypoperfusion? Hypovolemia, cardiogenic, and vasoregulatory. Our focus today is on vasoregulatory, that is sepsis and neck. So how does sepsis affect our myocardium? So in the sepsis, we know cytokines, TNF, and interleukin-1s are released, which actually stimulate the nitric oxide. And nitric oxide is a vasodilator, and it actually causes problem with the contractile dysfunction of the myocardium. There would be a global ischemia which will affect the myocardium along with endothelin inflammatory cytokines and interstitial inflammatory reaction. And leukocyte activation actually hampers the autoregulation part of the myocardium. So there are multiple roles, and finally what we see is decrease in the preload because of two things: absolute hypovolemia due to interstitial fluid loss and a relative hypovolemia due to increased venous capacitance. And later on, the contractility of the myocardium also gets affected. There is an abnormal peripheral vasoregulation, and this causes warm and cold shock. The systemic vascular resistance is reduced, and there is a vasodilatation. So that much happens to our babies with a septic shock. What happens in the warm shock? So there is a loss of vascular tone, and there's an increased systemic blood flow and a low blood pressure. It's much more difficult to recognize clinically. The cold shock will be having an increased vascular tone, the systemic blood flow decreases, and then is the fall of blood pressure. This is much more easier to actually find out. However, the time when we pick it up is very important, because if we prolong the treatment, it may go into irreversible shock. So close monitoring here plays an important role. So the key message here is septic shock has two phases, warm shock and the cold. They are difficult to diagnose. We need a close monitoring, and delayed treatment may lead to irreversible shock. So what do we do? How do we manage our shock? We have to take into consideration clinical assessment, vitals, some investigations, and our functional echo. Together, we will recognize the shock, we will determine the severity, define the etiology, and evaluate and treatment plan has to be made in. So what are the potential agents once we diagnose shock is we can use volume, we can use pressors, inotropes, and corticosteroids. Question comes what to use when. So it all depends on what we are dealing with. If we have a systemic blood flow reduction, we will be using different pharmacological agent. If we have decreased cardiac output or systemic blood pressure, it will be different. And if we have a vasoconstriction, it will be a different thing. So we have to recognize what exactly we are dealing with. So should we give our babies, whosoever are coming to us with hypertension, a volume, thinking it is a volume loss? True or false? I'm sure everyone would agree false. Why? Each normal saline is not equal to the blood pressure, as you can see in this cartoon. In how much normal saline we are giving, the blood pressure is not that much changing in all the babies. Each normal saline is not equal to superior vena cava flow. Sometimes it increases, sometimes it doesn't, and sometimes it may fall. So the key message is majority of the hypertensive preterm infants are not hypovolemic, and hence over-chalice fluid administration is to be avoided. What about pressors? Let's go to the case. 34-weeker gestation age, 1.4 kg infant, born to mom with preterm labor, secondary to severe chorioamnitis. We just heard about it. Baby is ventilated with persistent oxygen requirement after surfactant administration, and the MAPs are between 20 to 25. Poor urine output, prolonged capillary refill, and then we did the echo, because this is a time in a preterm baby who may also have PDA, and we did see PDA with a bidirectional flow and a high cardiac output. Now, to differentiate whether this problem is due to the duct or due to the sepsis, because we are now we get such babies a lot. So we did a functional echo where we saw bidirectional shunt, high cardiac output. Our LVOT is high and RVOT is high as well, which may happen in both. Then what do? We look at the resistive index. So when you have a high resistive index in the late onset sepsis, that's more in the favor of a sepsis. And hence, in this baby, what would you do? So I would say that volume, volume, and volume. So this baby definitely requires a volume. So after volume repletion, what would you recommend? Dopa, epinephrine, norepinephrine, dobutamine with dopamine? What do we do? This we can answer only when we know what these agents are doing. So dopamine in a low dose, it affects dopamine receptors where they will affect on the renal, mesenteric and coronary vessels where they will cause vasodilatation, increase in GFR and direct renal tubular effect. Very low positive inotropy effect is there. Dopamine in 2 to 4 dose has an alpha receptor effect where you will have a vasoconstriction, positive inotropy and a metabolic effect. And higher doses of dopamine has a beta receptor effect with a positive inotropy and chronotropy and peripheral vasodilatation. So dopamine, when they act on alpha receptors, causes vasoconstriction. What about epinephrine? Epinephrine in the low dose has an effect on the beta receptors, causing positive inotropy and chronotropy and peripheral vasodilatation. And in the higher doses, they have an alpha receptor effect on vasoconstriction and positive inotropy. So we must know this before we start these medications. And when we keep on increasing dopamine, we do have effect on mean blood pressure, which increases along with the cardiac output. What happens when we keep on increasing epinephrine? It also increases the mean arterial blood pressure. So what is the difference between dopamine and epinephrine? The studies didn't see much difference in efficacy to maintain the mean arterial pressure above gestational age. No difference in mortality or morbidity was seen. However, what was seen was that babies who were treated with epinephrine had greater increase in heart rate, higher lactate, low bicarb, and higher blood glucose. So this thing has to be kept in mind. And when you compare dopamine with dobutamine, what we see is that there is a much more increase in blood pressure with dopamine and very less effect with dobutamine. So one of the meta-analyses, when it compared these agents on a hypertensive preterm, found that dopamine administration was better to increase the mean systolic blood pressure in these babies, more than dobutamine, cholide, or hydrocortisone. And hence the key message is dopamine would increase the mean blood pressure in the hypertensive preterm babies. Epinephrine may be more effective in the term babies with sepsis. So these are the two type of babies we get with the sepsis. Infant with sepsis with high output, where your blood pressure may be low, output is high, and what we are dealing is low systemic vascular resistance. So what would you give in this baby? You will start with saline, and you may have to give more saline in these babies, and then look at the response, and then we may start with epinephrine or dopamine in this patient. However, infant with sepsis with low output, where you are dealing with poor myocardial function, perfusion problems, and higher systemic vascular resistance, in this fluid will not have much effect. You may give one fluid, but soon dobutamine would be a better choice in this kind of a baby. This is one way to look at it. The other way to look at it, take everything together. Clinical, where you look at heart rate, CFT, pulses, and urine output. Monitoring with the blood pressure. And lab investigations along with lactate, electrolytes, and your functional echo. Combining all of them along with inferior vena cava diameter. So how do we interpret inferior vena cava diameter? Because it gives a reference to CVP. So if your inferior vena cava diameter is less than 8 and you have more than 50% collapsible with respiration IVC, it's sure we are dealing with a low CVP and you have to give fluid to these babies. If the diameter is less than 8 but the collapsibility is less than 50, you may be borderline low, so too much of fluid is not required in these babies. Diameter more than 8 with less than 50% collapse is absolutely normal. And if more than 8 and there is no collapse, that means you are dealing with higher CVP. So when you combine all these, let's look at what we will do. Preterm baby with bad clinical parameters, with blood pressure being higher, lactate is high, and cardiac output is low. So what are we dealing with in this case? We are dealing with a baby with decreased cardiac contractility and increased SVR. So what do we do in this case? We will give our agents to reduce the afterload. So we will give dobutamine and milrinone. If we have a baby with bad clinical parameters, low blood pressure, high lactate, and high cardiac output. This means we are dealing with decreased cardiac contractility and decreased SVR. So there we are with something like sepsis and a mixed shock. And here we will have to give, along with saline, inotropes and vasopressors. So epinephrine would be our choice. If we have a baby with clinical parameters being not okay, blood pressure is plus minus, lactate is high, and functional echo is showing cardiac output high, we are dealing most likely with a shunt, that is PDA. And so we will be treating the cause. And this is the most common scenario where we deal with, where you have normal clinical picture, you have a normal lactate, you have a normal echo, but only thing what you have is a decreased blood pressure. So here it is an inconclusive blood pressure. Please don't start treatment in these kind of babies, but don't stop observing these babies. So you need to observe, but not to treat. So let's go to an algorithm where the time is very important for our treatment. We have a baby who is coming to us with shock. We'll recognize the shock. We'll look at the breathing. We'll maintain the airway. TABC will come. We'll follow the NRP guidelines. Start saline, and if baby is responding, you may go up to 40. Correct the hypoglycemia and hypocalcemia. Begin antibiotic. And if you are suspecting ductal dependent lesion, then only start prostaglandin. Baby is not responding, so it is a fluid refractory shock. You will start with dopamine. Dopamine not responding, it's a dopamine resistive shock. You will start it with epinephrine. It's not responding, so it is a catecholamine resistant shock. Now what do? We have to differentiate these babies into 3 groups. Cold shock with normal blood pressure with a poor left ventricle function. Usually you will give nitrovasodilators in milrinone in this baby with volume loading. Cold shock with poor RV function and PPHN, you will give inhaled nitric oxide. And the baby which we are going to deal with here, low blood pressure, warm shock, you will titrate your volume. You may start norepinephrine and vasopressin may be given, and you will try to make it as normal as possible. Still, if you have refractory shock, baby is not improving, you will start looking at pneumothorax, pericardial effusion, adrenal insufficiency, giving hydrocort, and sometimes you may have hypothyroidism, so you may have to give altroxin in these kind of babies. Still, baby is not improving, ECMO is the modality. So to summarize, neonatal sepsis with the warm and the cold shock. Warm shock is hyperdynamic circulation, high cardiac output, low PVR, and warm extremities. Cold shock is hypodynamic circulation, low cardiac output, high PVR, and cold extremities. So in the warm shock, you will always have central blood flow higher. The blood pressure may be normal or low. In the cold shock, you will have always a low central blood flow. Your blood pressure may be low or normal. And hence, the same thing, the key message for inotropic choice, infant with sepsis with high output, who will come to us with low blood pressure, high output, low systemic vascular resistance, volume in this baby, followed by epinephrine or dopamine, and infant with sepsis with low output, with a poor myocardial function, perfusion problems, and high systemic vascular resistance, volume will play a less role, and dobutamine will be our choice. With this, I think I have tried to simplify septic shock as much as possible. Thank you for your hearing, and these are my happy babies and happy moms. Thank you.
Thank you, Dr. Kushal, for this great presentation, and thank you for all the speakers for this very interesting and very useful session. I may ask the speakers to come to the floor.
Thank you.
Okay, so thank you very much for very thought-provoking session from initially shock to guidelines to long-term and to chorioamnionitis. So this is controversial. Whatever I said, half of the people here agree, half of the people not. And similarly, you are 5 people and the Tehsil is 6, so 3 of you agree, 3 of you don't agree. What we are doing in our practice, we did the antibiogram, as Hafiz said, and this is the comments for all of you, that you can give your suggestion. We are using CRP, but in my opinion, we are abusing CRP. And my team is sitting here every morning meeting. I raise this issue why we do the CRP. The CRP come 30, everybody is happy or everybody is unhappy. I don't know. The prolongation of antibiotic is due to 3 things. We believe on evidence-based medicine. Then there is experience-based medicine, as Dr. Eric and Hakam Yassin is sitting there. But there is something in this part of the world called fear-based medicine. If something happened to the baby, who is responsible? So that's why we are prolonging the antibiotics and we are abusing the CRP. So my comment from Dr. Tessie to Dr. Monica, anybody can do comment on that, what we should do. Start from Professor Eric.
So I would completely agree with you that mostly the reason why we're prolonging antibiotics is because we're afraid that something bad will happen, not only to the baby, but also to us. But I do think that there is, I believe, accumulating evidence that prolonged antibiotic therapy is actually harmful. And so I think that that's why it's important for us to change the paradigm, is to move away from saying we're protecting the baby from something by doing it, by saying we may be harming the baby. And that may be, at least for the very preterm babies, an increased risk of necrotizing enterocolitis, potentially an increased risk of fungal infection. For the term baby, there's, I think, good evidence now that there are long-term consequences, including extra weight gain, perhaps an increased risk of A to B with antibiotics early in life. So I think we need to change the paradigm. What I will say about the CRP is that I don't use it at all. I think it probably ends up creating a situation where we use antibiotics more frequently. And I think there is a paper that looks at the NICE guidelines where they recommended the CRP, and they actually showed that there was an increased use of antibiotics, not a decreased use of antibiotics in term babies. So I think that there's probably maybe more harm than good in that practice as well.
Okay, Dr. Dua. Oh, sorry.
I agree, CRP is not the absolute truth. Like Eric said, it should not be the only parameter you look at, but very often it ends up being the only parameter. But that shouldn't be. Look at the baby, the clinical condition, your cultures. It's good for ruling out, but not ruling in, is my thoughts on that. And what level of CRP is abnormal, it's anybody's guess. It's an indication of inflammation, not infection. So you have to look at the whole picture. I agree, and it does increase the unnecessary use of antibiotics. And you rightly said, in this part of the world, it's always fear, saying that if I don't treat and later the DOH comes after me, how will I kind of defend it? But I agree, it's probably redundant, but we still continue to use it.
Can I say something? Just few days back, we had a hot discussion and in one of our academic WhatsApp group, and I happened to say CRP is crap, and and I was bullied like anything. Yeah, so that's why.
No, that's too harsh.
Yeah, too harsh. I had to take my words back that I was too harsh. But what I mean is, it has more of a negative predictive value than a positive predictive value. And there are so many other reasons for CRP to be high. And I have seen in my practice people being really scared and starting antibiotic just based on CRP, which I would say shouldn't be done. Like, you know?
Yeah, yeah. Thank you very much. I agree with the colleagues. Whatever we speak, the neonatologists they will continue to do CRP. I believe, but if you understand that what's the benefit of CRP, then there will be benefit. So the CRP, if it's negative and the baby is okay, then the negative predictive value is very, very high. Now, there is the issue with the CRP, there is some false positive, and it reach around 30%. And this is the experience of the neonatologist not to start antibiotics if it is slightly increased and the baby is clinically is okay. Then you can go to the second option, which is the observation for 24 hours. This is my.
Okay. I have a question before we go for Dr. Eric. You know, like we tend in neonatology, it's a common scenario that we have uncomplicated C-sections, no rupture of membrane, you know, babies like premature delivers, they will have obviously, most of them respiratory distress. But the question is, we rush into antibiotics on these uncomplicated C-section deliveries. There is a study done, I believe, at your institution last year by Dr. Dustin Flannery. She looked at, or he looked at the scenario, and the conclusion is, regardless of gestational age, uncomplicated C-sections, you should not start antibiotics. And we're still scared. When you have these premature babies, they're going to end up on antibiotic regardless, second day. So what do you think about this practice, or changing the practice?
Yeah, so what I would say is that's what we're doing in our institutions now, is in a very specific population, no labor, cesarean section for maternal indications, no rupture of membranes, no sign of chorioamnionitis. Those babies, the first pass is to not start antibiotics. But if they're critically ill, they get antibiotics. And so I think that's the differentiator is if the baby's critically ill, we opt to antibiotics, but many of those babies will have respiratory distress, not have hypotension, will just look fine, and so they wouldn't get started on antibiotics. I think people have a very low threshold for deciding to start antibiotics because of this fear-based medicine, but I do think that there is a population that we could probably avoid it in, and I would advocate that be the case, but not extend that out to other potential risks in preterm babies, if there's rupture of membranes or other unexplained labor or something like that.
Okay, thanks. Dua?
Thank you for the four speakers, really wonderful talks. My question is mainly for Dr. Hafiz, but I'm really happy to hear from other speakers. Do you think it's now the right time to develop unified guideline to be for management of early onset sepsis, to be used in UAE, whole UAE, or at least in Abu Dhabi? Because what is being done in this hospital, for example, is different from another hospital that is only 10 kilometers far away. Provided that the necessary training is provided for the staff to make the observations and to closely follow up the babies. Thank you.
Thanks, Dua, for the question. I completely support that premise, but as I said in my talk, every hospital is different in terms of the resources they have. For example, and the antibiograms and your local flora and fauna. So it'll depend on that. Guidelines, at the end of the day, are guidelines. They're not laws. It's a framework to use, and you have to tailor it according to your local circumstance. For example, the resources you have at Danat might be different from what I have at Corniche in terms of what the nurses can do, what the midwives can. So if you're going to have enhanced observations, you need that much more dedicated manpower and the appropriate number of nurses and doctors to deal with that. But having said that, the basic principles can always be unified, and I have Faisal standing right behind you. He's updating our SAHA guidelines at this point in time. So at least in a group of hospitals, where the resources are similar, we can practice the same. There's no reason why it can't be rolled out and act as a model for others to adopt, but always look at what's available locally is what I would say.
And if I can just say a couple of words about the sepsis calculator as the U.S. representative, because it is very, very commonly used in the U.S. right now. The important thing to understand about the sepsis calculator is it's based on Bayesian analysis. You need to know your pre-probability of sepsis. And so you need to, there's an option in the calculator to change the probability of sepsis. So you should know what your sepsis probability is in your local area and change that accordingly. The second thing is no methodology is going to catch every case of sepsis. And so just because the sepsis calculator misses a few cases is not a reason not to use it, in my opinion, because every situation will miss cases, and restricting antibiotics in term babies who aren't infected is probably a good goal. So that's my personal opinion reflecting what's happening in the United States right now.
Yeah, and regarding the guidelines, we have through the neonatal service line, we're building the guidelines. Dr. Faisal, he can talk about it more, but he is in charge of, leading this project. Dr. Faisal?
Yeah, I thought next week I'll finalize the guideline. I think I'm changing my mind again. I think I did that in Richard Poland, I think before COVID. He came in and talked to us about chorioamnionitis, and we tried to put babies really above 34 weeks to say really, majority of these babies, if there is chorioamnionitis, history of chorioamnionitis, they're going to declare themselves the first 24 hours. So they're going to declare, the one who's going to be sick, they're going to be showing, the first 24 hours. We decided actually going to put it as an option because we have to take consideration what services we have in Emirates of Abu Dhabi. You have to have enough nurses to actually do regular observation. That's something we couldn't do. When we have one nurse looking after 5 mothers and 5 babies on postnatal, how are we going to ask her to do observation every 2 hours? I mean, the current observation we do for babies on postnatal is every 12 hours. So you can see that makes it really difficult. So we have the option, if you can do that, fine. If you can't, then you have to really screen and actually start antibiotic. Or the other option, bring the baby to an ICU. If you do that, or a special care, that will block beds. That actually causes more problem. So I think in neonatology, especially with this area, with lack of the evidence, we don't really practice what we preach. I mean, that's the way I find it. It's difficult when you practice it. When Dr. Hafiz says 80, I think, to 450 that you have to treat, you have one who you're going to miss. In Abu Dhabi currently, or in the Middle East, we do not have a baby who goes home after 48 hours, comes back, collapsed, and dead on arrival. We do not have any post-mortem. It's very difficult to say what was the cause of death. If somebody goes to say, well, CRP was 50, but the baby was well, on the probability, people say, well, actually, that was probably sepsis. So it makes it really, really difficult. So I think what I want to really take into account when I do the guideline, all the other factors together, reducing the use of guideline. I was going to ask Dr. Arik, if you have a 24-weeker delivery because mother had real preeclampsia, baby is delivered and had respiratory distress because of premature. Will you start that baby on antibiotic when actually there is no indication, besides being extreme premature but delivered by C-section because of maternal reason? Because most of us, we do use it.
So I think that the answer to that is your first pass should be, I'm not going to start antibiotics unless the baby gives me a reason to do so. And it really is, if they're critically ill, I would start antibiotics. If they're not, I would hold off. And the baby's not going anywhere. You can observe the baby in the NICU. But I think that it's not universal. It's based on what the baby is doing. And even if the baby's critically ill, most of those babies probably aren't going to have sepsis. But I think many of us would not be comfortable not starting antibiotics. To your first point, I completely agree with you that whatever you do with early onset sepsis in the term baby is dependent on your local construct of care. Most places can't do these 2-hourly observations. Even in the United States, that's not possible because they're couplet care. They're in with the mother, or they're not in a nursery. So I completely agree with you, which is why when you look at the adapted sepsis calculator, if the baby's got symptoms, you start antibiotics, even if they have a low risk score. So I think that clinical judgment's not removed from that, but you've got to be sure that your construct of care is keeping the baby safe. So I completely agree with you with that.
So one more question. So
Sorry.
the team can take break, and we start the next session. Question.
Thank you for really very high topic, all of you. I have a question and maybe your suggestion. If we, do you think that still is most important clinical condition of the baby? If we are following American Academy of Pediatric recommendation and NICE guidelines, if baby is sick, start antibiotic therapy. Also, to making decision not to treat or stop to treat is for the stable baby, maybe with the risk which we will follow up. Do you think that if we have a baby which clinical condition are not well and maybe increasing respiratory distress, baby is hypotensive, however blood culture is negative, that we will continue start with antibiotic therapy? And maybe one suggestion for the septic shock. Now is more, I believe, easier algorithm for the septic shock. Now epinephrine and norepinephrine are first line therapy for the septic shock. Dopamine only if we haven't epinephrine. This is what I find. What is your? All of you.
Sorry, if I understood the question correctly, so if you start antibiotics in a baby, everything is negative, but the baby is critically ill, would you stop antibiotics or not?
Yes, yes.
Personally, I would, but if you asked people in this room, 50% probably will continue. But that's probably not the right option. The baby can be sick due to various reasons, not just sepsis. So if everything else is telling you that the baby is not septic, my recommendation would be to stop antibiotics.
Yeah, and what I would say is I think it's the issue between opt-in and opt-out, right? Because I think that if you have an automatic stop on your antibiotics, then you have to actually think, I'm going to continue the antibiotics. That may result in people saying, oh, I don't think they're really necessary. But I think that blood cultures are pretty reliable now in 2023. So if they're negative and you're using an adequate volume in your blood culture bottle, I would believe the blood culture results. But if you have a baby who's sitting in front of you who's on an epinephrine drip, on high frequency ventilation with negative blood cultures, I would probably continue antibiotics. So I really, but you need to be, at least think about it.
Excuse me, Dr. Eric, I have a question. I'm from Al-Qasimi Women's and Child Hospital. What's your experience about the cytomegalovirus infections in your unit, and what time you are giving the treatment for the cytomegalovirus? Because we are facing a new challenge for the cytomegalovirus infections in our units. I am just asking about your experience and what's your advice and when to treatment and how long you are giving the treatment for the cytomegalovirus.
So I think the question was what our experience is with cytomegalovirus. So we've started to look in babies who have unexplained clinical deterioration with negative blood cultures. We've started to look in at least one of our hospitals for cytomegalovirus, and we find it with some regularity. There's a new proposal for the Neonatal Research Network to do a larger study to have us understand what the actual risks are and what the clinical conditions are and what the clinical outcomes are. So I think there's more to come on that. But my point was there are other reasons for babies to have a clinical deterioration which may be unrelated to bacterial sepsis, and it's worth at least thinking about other things in mothers who are providing breast milk to their babies.
I'm just asking, is that positive? Every case you are treating?
Yeah, I think we should, because the team has to come back in 11:15, so you can have the chat one-on-one outside, so we can give our colleagues a break. Thank you very much for this great session.